Hello everyone. Today we are going to discuss about the blood transfusion therapy. Blood transfusion therapy involves transfusing whole blood or blood components that may be lacking in the patient. 1 unit of whole blood consists of 450 ml of blood collected in 60 to 70 ml of preservative or anticoagulant. So basically the pack of 1 unit of PRBC or whatsoever the blood component is, it contains 450 ml of blood along with 60 to 70 ml of anticoagulant that helps in keeping the blood in the liquid state without any coagulation. Whole blood stored for more than 6 hours does not provide therapeutic platelet transfusion, nor does it contain any therapeutic amount of labile coagulation factors. So that is why the anticoagulants are important, because if it is stored without any kind of coagulant, then it will not be able to stay for more than 6 hours. Now the components of blood. These can be packed RBCs, that is 100% erythrocytes, 100% leukocytes and 20% of plasma originally present in 1 unit of whole blood, indicated to increase the oxygen carrying capacity of blood with minimal expansion of blood. Then it can be leukocyte, that is poor packed RBCs, indicated for patients who have experienced previous febrile and no hemolytic reactions. Then third is platelets. This can be either HLA, that is human leukocyte antigen, matched, or it may also be unmatched. Then it can also be granulocytes. These include basophils, eosinophils and neutrophils. It may be fresh frozen plasma containing all the coagulation factors, including factors of 5 and 8, that is the labile factors. Then another component of blood may be single donor plasma, that is containing all stable coagulation factors but reduced levels of factors 5 and 8. And this is the preferred product for reversal of comedine induced anticoagulation. Then there may be albumin, that is a plasma protein. It can be a cryoprecipitate, a plasma derivative rich in factor 8, fibrinogen, factor 13 and fibronectin. Then factor 9 concentrate, a concentrated form of factor 9 prepared by pooling, fractioning and freeze drying large volumes of plasma. It may also be factor 8 concentrate, that is concentrated form of factor 9 prepared by pooling, fractioning and freeze drying large volumes of plasma. Prothrombin complex can also be there, that is containing prothrombin and factors 7, 9, 10 and some amount of factor 11. Then we are going to see the advantages of blood transfusion. The first advantage is it avoids the risk of sensitizing the patients to other blood components. And it also provides optimal therapeutic benefit while reducing the risk of volume overload. So if you are directly transfusing the blood, it is giving you what you are needing without any risk of increasing the fluid overload in the body. It also increases the availability of needed blood components to larger population. Now we are going to see the principles of blood transfusion. First is in case of whole blood transfusion. It is generally indicated only for patients who need both increased oxygen carrying capacity and restoration of blood volume when there is no time to prepare or obtain the specific blood components needed. In such cases, we do the whole blood transfusion. Then packed RBCs, these should be transfused over 2 to 3 hours. If patient cannot tolerate volume over a maximum of 4 hours, it may be necessary for the blood bank to divide a unit into smaller volumes, providing proper refrigeration of remaining blood until needed. 1 unit of packed RBCs should raise hemoglobin approximately 1% and hematocrit 3%. This is important from our nursing point of view. In this one paragraph, you get 2 to 3 questions that are commonly asked in the competitive exams also. That what should be the time duration in which the RBCs should be transfused. So it is around 2 to 3 hours and not more than 4 hours. Then in 1 unit of packed RBCs, the hemoglobin raised is approximately 1% and hematocrit is 3%. Then platelets, administer as rapidly as tolerated, usually 4 units every 30 to 60 minutes. Each unit of platelet should raise the recipient's platelet count by 6,000 to 10,000 per mm3. However, poor incremental increases occur with alloimmunization from previous transfusions, bleeding, fever, infection, autoimmune destruction, and hemolysis. Plasma, because plasma carries a risk of hepatitis equal to that of whole blood if only volume expansion is required. Other colloids or hemolyte solution, that is Ringer's lactate, are preferred. Fresh frozen plasma should be administered as rapidly as tolerated because coagulation factors become unstable after thawing. The next factor is albumin. It is indicated to expand the blood volume of patients in hypovolemic shock and to elevate the level of circulating albumin in patients with hypoalbuminemia. The large protein molecule is a major contributor to the plasma oncotic pressure. Then cryoprecipitate. It is indicated for the treatment of hemophilia A, von Willebrand disease, disseminated intravascular coagulation, and uremic bleeding. Then factor IX concentrate, indicated for the treatment of hemophilia B, carries a high risk of hepatitis because it requires pooling from many other donors. Then factor VIII concentrate, it is indicated for the treatment of hemophilia A. Heat-treated product decreases the risk of hepatitis and HIV transmission. Now the next is complications. The first complication is allergic reaction. It is caused by sensitivity to plasma protein of donor antibody which reacts with recipient antigen. Then is febrile or non-hemolytic. It is caused by hypersensitive to donor white cells